For those of you who are interested in listening, so am I. So let's get going. I have a timekeeper. It looks like we have at this point about 25 minutes. Is that right? To chat with Brent James. So thank you so much for coming here this morning. I've been asked to do the interview as Dr. James has asked, a little bit nervously, as I'm used to being a psychiatrist. What might this be like, or is there going to be a diagnosis? And in referring to Professor Pickett's lecture, I noticed that in the most favorable position in the area, she's not here, in the area of trust, were the states of Utah, where you live and trained, and the state of Wisconsin, where I grew up and trained. So in terms of safety, right here in this interview, I think it should be okay. So let me give you a little background about Brent James, which we didn't otherwise hear. Dr. James was born in 1950 in Idaho, actually in Blackfoot, Idaho.
Blackfoot, Idaho.
Where he grew up on a cattle ranch. He's the oldest of 6. All boys, all girls?
2 girls, 4 boys.
And where are the boys in the hierarchy? You're the oldest.
Yeah.
And where's the next one?
Girl, boy, 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 boy.
All right. In an article that was in the New York Times Magazine a few years ago, which you must be plagued with, one of the comments was that he spent a lot of time on a tractor growing up, and sometimes he'd be waiting for a water hole to fill up or something, and while he was on the tractor, he would be reading a calculus book. Was that apocryphal, or was that true?
That's actually true. It can be really boring.
Do you mean reading a calculus book?
No. Usually waiting for a ditch to fill up. It was all flood irrigated, and here's the craziness. I had an interest in lasers. They were brand new. Fascinated by them. We started to investigate them a bit. I went to a high school where calculus was not available in the high school at the time. And I wanted to build a laser, and it became clear that if you're going to build a laser, you had to know some calculus. And one of my teachers gave me an extremely good book for self-learning by a guy named Agnostal. And so it was toward a goal, toward an end. I never accomplished the end, by the way, of making the laser.
Well, we'll talk about that a little bit later. How many kids in your high school?
130 in my graduating class.
And you had the good fortune of a teacher who could hear you, respond, and give you something.
Probably the best teacher, one of the best in my life, was the fellow who taught math at that high school, a fellow named Ellison.
And what about him as a teacher made him so special?
He related well to the kids in the class. He could actually interact with us pretty well, and at the same time he had a very high academic standard. It's a mixed class. The way I think about it is the football and basketball players in the class, usually in our community, do not set very high academic standards. So I was kind of on the thinking side of the line, not the sports side of the line, and he managed to engage us all. But for someone like me, he had some background materials that went in deeper, and he routinely brought them forward. He also set higher expectations. He based his expectations on where you were, kind of.
Important figures in a life.
Oh, yes.
So you went on to university, at the University of Utah, those were 1967, 68?
Actually, the truth is I served a mission for the LDS Church in Korea for a couple of years, 1 year of university.
I was going to ask about that.
And then 72 is when I really got back into the university.
Do you want to say a minute about, for those who don't understand about LDS and the Mormons and mission, what that means?
You're offered an opportunity at your own recognizance if you choose to go serve a mission, usually in a foreign country. A large number of LDS young men do. Typically is 2 years. You pay for it yourself. It's fairly highly regimented. You're kind of told where to go. given a particular assignment. It represents true commitment. One of the things that comes out of that is you develop a true love for that country and its people. You kind of go native for a while, and it's interesting. In little rural Idaho, Utah is very, very cosmopolitan in that sense. For example, the U.S. Army has its major language groups in Utah because we cover basically every language in the world, people who are fluent in them. But yeah, it's a real service, and we do it when you're 19 years old, 19 or 20 years old.
A formative age.
Yes, it is.
What happened to you formatively in those years?
You learn how to work very, very hard. You learn how to suffer a fair bit of disappointment. You get a much better sense of how the rest of the world lives, and a much better sense of, where true happiness resides. Korea, frankly, was a third world nation at the time. Very, very poor, very low living conditions. And you come to understand that human happiness doesn't depend particularly on income level. At least that's one of the things I learned out of this whole thing.
So happiness is not a metric, and you're known so much as from the time on a tractor or creating a laser to noticing in those years something that seems qualitative. But that was what you took home with it, was some measure of happiness.
Yeah. Here's the core thing I think I learned. I think most physicians and nurses understand this. One of the real sources of happiness is service to others. You're defined by how well you serve. And that 2 years in Korea was just an intense epitome of that. It's about serving others. You see, it was a real sacrifice. You paid your own way. You took 2 years out of your life to do it. And you learn the value of service.
I've often thought that the concept of physician compensation so often focuses on salary. And there's another piece of physician compensation which has to do with the exchange of gratitude, the receipt of having done service effectively, that motivates physicians, I hope, to choose the field in the first place.
I think that's really true of us. I said it when I was speaking. It's a little soundbite, but I really believe it. We count our successes in lives, don't we? Far more important than the income you get for someone who's in medicine. Have you read Dan Pink's book, by the way, on Drive, about things that motivate people?
Oh, yeah.
Fun book. He talks about this extrinsic motivation, pay, is the main one, versus intrinsic motivation. He doesn't explore this factor of service, but I think he should have. It certainly matches what he was saying in the book, and I think it's what draws us into medicine. I really do. The science is interesting. You know, it's a funny story. I was in a straight-through PhD physics program. And one day I was sitting in the physics lab. I was working my way through school. I actually sent some money to my parents while I was in school. That's the way it worked for me. And we had a postdoc, in his second postdoc, out of Columbia, a really top-end physics program. And one day he told me I was insane. He said, "You're crazy." He said, "You think you're going to get a teaching job in physics?" Which I kind of did. I really hadn't thought about it very much. It just was fun. He said, "There's a waiting line, 200 people long, for any teaching job in physics." He says, "There's no work here. There's no real life here." And I said, "Well, what would you do?" He said, "Well, medicine. Great questions, easy money," is what he said. And I thought, what the heck? I was in the hard sciences, and so I just went and applied. I hadn't been in pre-med at all. And I'll be darned, they accepted me. I took the MCAT and applied. And I remember in the interview, they said, "Why are you interested in medicine?" I said, "Well, it looks like I'm trained as a researcher, and I plan to go do research. And if I never see a patient in my life, I don't much care." That's what I actually told them. And
this
then
was after your service.
Yeah, but I was not thinking of it this way. I was thinking of it as fun science. But then I got into the clinical services, and a world opened up. You know, that's when the service part kicked in.
I was going to say, the world you had been in reopened.
Oh, yeah. I mean, I didn't know that medicine offered that. But it did, and it did in spades. Well, what serendipity, really. And the next thing you know, I'm in a surgical residency, you see. But just pure dumb luck. Good luck, extremely good luck. I had, by luck, the good fortune to stumble into the finest profession that God ever created, and that's practice of medicine. Good science, ability to serve.
How did you pick surgery?
Oh, again, I don't know, just natural. I don't think I picked surgery. I think surgery picked me. It just resonated. I'm really good with my hands. At one level, I like to solve things right now. You see what I mean? So that's kind of a surgeon, isn't it?
Right. A chance to cut
is a chance to cure. Exactly.
So from the surgical residency, you went to the National Cancer Institute to pursue your research interests.
In cancer, yeah.
In cancer. And where you studied variation in the staging of cancers.
Yeah. Then I went to the American College of Surgeons with the Commission on Cancer. That's where I figured out you really couldn't understand cancer without statistics, so picked up that master's degree in statistics. And then came here to do a fellowship in biostatistics at the Dana-Farber Cancer Institute.
So measuring. I mean,
Measuring.
Still the kid with the calculus book.
Oh, yeah.
Was there a moment, or if this isn't too romantic, an epiphany where you saw what you wanted to do, where which you could trace back what you do now to? Research is generic, and numbers are something you've always loved. Service was a piece of it. Was there a moment, an example, a case, a project, a person?
It actually came later, but there was. So I was always good at math. I understood the value of measurement. Measurement's your ability to see what's happening. I mean, some things in life, the effect size is so large you can see it with the naked eye. But so much of what we do you can't see with the naked eye, and it depends upon robust measurement to do it, so you gain those skills. It was actually after I got to Intermountain, we were studying variation in clinical practice. Now, to that point in time, everybody had looked at variation as hospitalization rates, so you'd use usually insurance claims databases, Medicare database, for example. That's what Wenberg did at Dartmouth. And they'd look at variation in hospitalization rates. Well,
and you'd been into variation in your first research project.
Yeah.
So variation was
an old friend.
Yeah.
I'd never seen it in medicine before. I had the same set of preconceptions that any well-trained doctor did. Well, we decided to push it down a layer. We said, okay, we know there's variation in hospitalization rates. I wonder if physicians in the same hospital treat patients the same way. That was the question we asked. And what we demonstrated, I think we were the first group in the world to do so, is that variation moved down to the level of individual physicians treating individual patients. It was much more clear at that level what was going on. You could see it so much more clearly. And so we had the data. We studied 6 clinical areas in 2 years: transurethral prostatectomy, open cholecystectomy, total hip arthroplasty, bypass graft, pacemaker implementation, community-acquired pneumonia, and they showed very similar patterns across all of them. Seemed to be specially independent. And then a colleague, a friend, Paul Batalden, pediatrician from Minneapolis, now at Dartmouth, introduced me to a statistician named W. Edwards Deming. And Dr. Deming had a theory that described what we were observing.
So you met
Oh, yeah.
Deming?
And I'm really dating myself.
I was going to say, was Deming as famous as he became?
Yeah. I met Dr. Deming and actually worked with him. He helped me write what I think was the first paper on clinical quality improvement.
Had he been into medicine at all?
No.
So you introduced...
Oh, he knew Dr. Batalden. He knew other physicians, and it's interesting. What happened is I wrote up what we were finding, and I sent it to him, and I got back about 10 pages of handwritten notes. And worked with him, and he helped me develop this monograph, really, published in 1989. And he refused to put his name on it. He was getting to the end of his life, and he said, look, this is for your generation. He said, I'm not going to do medicine. He says, it's your job to do medicine. And that was his way of saying, get moving, guys. But what happened with it, John, is that that theory was so compelling. That was it. Deming had figured it out. Now, he hadn't applied it to medicine. And
but that was, for our field, the passing of the torch.
Yeah, for me at least, for me personally. You know, that's where Don Berwick got started too. That's where all of us really got started, was from Deming.
So you had been here in Boston School of Public Health, where you're still on the faculty. They're still getting you for, I'm sure they're paying you a generous salary to do that, but lots of compensation. And you ended up moving back to Utah, joining Intermountain, and beginning what you're describing. Do you think you could have done it in an academic medical center where allopathic docs look perhaps too much for negative findings and can somehow obstruct and maybe not have, because we just saw on the list, because it's on the East Coast, so there's not much trust out here, and maybe there's more trust in Utah. Could it have been done here?
You know, I don't think it could have. I don't know if people today can appreciate how radically counterintuitive that was at the time. Deming's big idea, the one that really got us going, was this idea that higher quality almost always drives lower costs, and that was so radically counterintuitive. I mean, directly against all my training. Higher quality meant spare no expense. I was trained that it was unethical to talk about cost when working to save a human life. That's what I was taught. And meet with Deming, and he says, no, higher quality means lower costs. We had this trial running back at our flagship LDS hospitals, led by Dr. John Burke, head of infectious disease. We published it in January of 1991 in New England Journal of Medicine. It was the first trial on timing of prophylactic antibiotics for surgical wound infection. So the old foundation for all the NS-QIP measures out of the College of Surgeons today. That was that article. And I come back to John, and I say, you know, this guy Deming, he says higher quality should drive lower costs. Have you ever thought of tracking cost outcomes as part of a trial? Now, there's a radical idea. I mean, nobody did that. And we talked it over and thought it was really interesting. He said, well, how will we measure cost? By serendipity again, we had a fellow in Intermountain. He was on the administrative side, a guy named Steve Busboom, who built one of the world's first activity-based costing systems that some Harvard profs are now calling for the world to adopt. We had him started in 1983. And Busboom knew how to measure cost. And what we did was throw cost outcome into the trial. So here you have some clinical investigators. We knew how to measure outcomes, right? That's our life. That's what we did. It turns out cost is just one more metric. Just toss it in. And within about 6 months, we'd shown that as our infection rates dropped, our costs of operations were falling profoundly. And we demonstrated that Deming was right.
I'm still thinking of that kid on that tractor, and from what I learned in calculus about so many variables.
Yeah.
And what you're saying is here was a significant variable that hadn't been in the calculation.
Yeah. And frankly, if I had been in Boston, it never would have arisen as a topic, because we had a particular way of seeing the world, and what it did is give you a new way of seeing the world.
What gets you really mad?
Oh, my. I don't know if mad's quite the right term.
Well, maybe that's not allowed, but you know what I mean.
Yeah, I get really cynical. I believe that sometimes our preconceptions cause us to seek solutions in the wrong places. And it makes you more sad than mad. And I think we practice that as a country fairly routinely. Our preconceptions say, seek a solution here, where if you took an objective, completely kind of evidence-based view, it'd be right over here and it works better. You know that you have to wait for the group to kind of mature in their thinking. And it's surprising, some groups, they surprise you, they come so fast, and others, you wait for decades for the movement to occur, you see? And that's what's troubling, is we could move faster.
So it reminds me of the story of Ernest Codman. Now, Ernest Codman in this group may know about him. He was a surgeon at Mass General Hospital, my hospital, and early on, he had a principle where he would measure what happened, he would record what happened with his patients. They were called end result cards. And then, that was good, but then he wanted to make those public for people to know what was happening. And on the trust scale, this was not something that the Brahmins and the owners of the hospital were interested in. He was basically, in 1911 he left the full-time staff, and in 1914, after making it much more public about accidents and errors, he lost his privileges.
Yeah, he actually, the famous cartoon hanging on the wall of the Countway Museum of the medical profession represented as a ostrich with its head in the sand.
What do I have? Can you see without those glasses?
I can't.
Put those glasses on.
On your tie. Is that the ostrich? It is.
Yes.
Holy cow, it's an ostrich.
This was not a scheduled moment. So, when you tell the story about what makes you cynical or frustrates you, that was 1914, where he was mustered out.
Yes. You know, his style was probably not conducive. He should have been a psychiatrist. I was telling you, if I had a choice of another profession, it'd probably be psychiatry. What's that old joke about psychiatry? How many psychiatrists does it take to change a light bulb?
Let me think about it.
No. The answer is one, but the light bulb has to want to be changed.
Yeah, right. I was thinking, in terms of variation, the psychiatry joke is, if you want 3 opinions, ask 2 psychiatrists.
Right. Well, you know, I think the difference between me and Codman, he saw the same truth. His method for getting his colleagues to engage was quite different. You know, I don't think he practiced very good psychiatry.
When I went to my first IHI conference, I went to the book section. And there in the book section, about half the books were on the science of quality and safety, which was on the agenda. That's what the conference was about. Half of the books were about change management.
Right.
I personally have scars of trying to make changes, and which didn't succeed not because the idea, I think, was wrong, but I couldn't move people to change. How do you do it? Have you had failures?
Not many, 1 or 2. My favorite book on change, speaking of that library you're looking at, is by a guy named Rogers. It's called Diffusion of Innovation. It was done initially as a PhD dissertation, then turned into a fairly famous book. He's the guy who talked about innovators and early adopters versus the early majority, late majority, and then what he called laggards. So as you look at a population of people, you realize they're not uniform. What I did was basically live Rogers' book. I would go into our community in Intermountain in Utah, and nearly always I started to measure. And what I'd do is find 2 or 3 or 4 physicians who wanted to engage. They're always there. And rather than worry about the other guys who would fight, just didn't spend time with them. Went with the guys who were interested, right? And what I added usually was rigorous measurement, the ability to see what was happening. And in all honesty, John, it was just plain fun. You know? And the next thing that would happen is we'd start to get some results. You'd kind of fail towards success. You'd try some things, most of them wouldn't work. You'd find something that did work. And we had data to back it up. And then next what would happen, so think of those as your innovators. My job was to help them succeed and then to advertise their success. You see? I think it was as much the word of mouth from a trusted colleague as it was the data. But I'm not that trusted colleague. I wasn't practicing actively in that area at the time. But it's somebody they saw every day in the hospital, respected their clinical acumen, you know. Well, next thing you know, you have a few more guys participating, and they're showing a result. And the next thing you know, you're through your early majority into your late majority. These are the guys who say, be not the last to abandon or the first to adopt. And they're really important to an organization. They stop you from doing stupid things too fast, all right? But then they start to swing, and the next thing you know, you have a new culture, a new standard for the whole thing, you see?
Let me ask Joe one more question. What's your dream?
I really stated it. I want to see two things before I finally quit, and I plan to quit when I'm 90, by the way. It might take a while. I honestly believe that we can achieve those levels of performance that I was talking about. The fact of the matter is that 28-year gain in life expectancy is attributable to healthcare delivery, public health, and direct practice of medicine. We fundamentally redefined what it meant to be a human being. The difference between 49-year life expectancy and 77. That's straight home to the house of medicine. The evidence is pretty strong for that. And then you see that we execute correctly 55% of the time. You see this list of problems, and you realize that that degree of achievement was just the down payment. Well, I'd like to see the completed edifice, if you will. I'd like to see the profession functioning at that level. A secondary effect that I didn't talk about, it turns out if you build it in as a learning system, your rate of academic production, your rate to do studies, to learn, just explodes up. So one of my goals, this is measurable, is I'd like to see Intermountain as a community-based health system produce at least 1,000 trials in a single year. And that's actually not an unreasonable statement. As a community health system, we currently produce more published articles than most typical universities because we've embedded in our care delivery the ability to learn from our patients and the routine practice of medicine. Most academic medical centers can't say that, you see. I think it's going to become the norm. But this ability to learn and advance our science at the same time that we execute correctly, and then the foundation upon which it rests, improve our level of service. When I say the people who seek our help in their greatest hour of need, that's exactly the right thought.
And on that thought, with the end result still pending, thanks so much.
Thank you.
Thank you very much.